So it is a several-part question, so let me just kind of talk through some of the issues. Of late, we've learned more about which cancers we need to treat and which ones we don't necessarily need to treat but need to watch. And there are kind of two ideas that are out there. One is active surveillance, which means this would be in somebody who is young and healthy enough that we would still consider treating them if the cancer started to progress locally. Watchful waiting might be in an older individual where we're probably not going to do local treatment, surgery, or radiation. We would, if the cancer advanced, we might give systemic treatment, but most men won't need that, so we watch them. So we can identify those cancers. Those tend to be lower volume Gleason 6 cancers. I'm assuming this is a somewhat savvy crowd who's heard the idea of a Gleason score before, many of you. That's the pathologic grade that we give, that's given by the pathologist as they look at the tumor under the microscope. And about half or even more of cancers are these Gleason 6 cancers, which we used to treat and mostly cure, but as we started to look at this, we started to realize that maybe we were curing people of a cancer that wasn't going to kill them. And we decided instead to switch to watching these, and if they start to get worse, then to treat them. The question is, how do you watch them effectively? And we're not perfect at that. So we're still trying to kind of understand the best way to do that. But the things that we have available to us are PSAs and rectal exams, which are the relatively easy things to do. There's the multi-parametric MRI that Dr. Lutz mentioned in the question, which is an MRI, a magnetic resonance image. It's a radiologic test that lets us look at the prostate. We can see detail in the prostate and sometimes identify cancers in the prostate. It's not a cancer diagnosing thing, it's a cancer suggesting sort of thing. So we can use that to monitor, and then a prostate biopsy. Most men who are diagnosed with an early stage cancer, what we recommend is doing some kind of a confirmatory test, and that could be a biopsy, it could be an MRI. The other thing that we didn't talk about is a genomic test. There are several different companies that make tests that we can used to get kind of it's a different way of looking at the cancer. It's not under the microscope so much, it looks at the genetics of the cancer. And we're just at the very beginning stages of trying to understand that. But there are some tests that can predict a worse or better cancer a little bit. And then the music group that Dr. Lutz mentioned is the Michigan Urologic Surgery Improvement Collaborative, which is a statewide collaborative Michigan urologists. Almost every urologist in the state is part of it, and we've taken on a series of projects to try to improve prostate cancer care in the state of Michigan. One of them is to get a robust active surveillance program going, and in order to do that, we had to have some kind of a guideline as to how to do active surveillance, because there were a lot of different ideas about how to do that. So the music guidelines would suggest if you have a low-risk cancer, you get one of the confirmatory tests, a genomic test, an MRI or a repeat biopsy within the first 6 months to be as sure as you can that this is a low-risk cancer. And then you're followed. And at some point, if you haven't had a biopsy initially, probably doing another biopsy would be recommended at a year, 18 months, 2 years, depending on how actively you're going to be surveilled. And that comes down to a discussion between the physician and the patient. You're looking at a lot of different things that come up in the discussion. There isn't really kind of a one-size-fits-all way to do that discussion. So we talk to patients and decide how frequently and actively we want to repeat these tests going forward.